Good afternoon, everyone, and welcome to the University of the Philippines and the Philippine Health Insurance Corporation's Stop COVID Deaths webinar series. This is the 8th installment of the webinar series, and today we have a very special resource person who will be talking about something that's close to our hearts. I'm Dr. Raymond Francis Sarmiento. Magandang araw ng kalayaan po sa ating lahat. And with me, as always, is my partner in crime and my beloved mentor, Dr. Susie Pineda Mercado, Board Director of the Philippine Health Insurance Corporation. Dr. Susie?
Hi Raymond, magandang araw po sa inyong lahat. Happy Independence Day. I don't know if it's a slow day for the hospitals, but just the same, Happy Independence Day to everyone. Sama-sama po tayo ulit. We'd like to greet all of you who are watching on with us in the webinar right now, those of you who are watching on YouTube, and of course, those who are watching on the playback. Because sometimes people can't make it at this particular point in time, but you can always watch it on the playback through TVUP. We've got a very interesting topic today, and we hope that you will make this Friday noontime webinar time a habit so that we can all continue to learn about what we can do to stop COVID deaths. Raymond.
Thank you, Dr. Susie. Before we start, like I do always, we would like to acknowledge, and this webinar series po will not be possible if not for the collective effort of the University of the Philippines Office of the President, represented herein by Executive Vice President Dr. Teodoro Herbosa, the Office of the Vice President for Public Affairs, represented by Vice President Elena Pernia and Assistant Vice President Rica Abad, and also Director Timmy Cabana. We also have help from the ITDC, which is led by Director Paulo Paje, as well as TVUP. Yun pong pinupuntahan po natin para sa ating YouTube. It's directed by Dr. Gigi Alfonso, and also at the UP Manila side po, we have the University of Philippines National Telehealth Center, National Institutes of Health po, the Philippine General Hospital colleagues, and as well our partner, the Philippine Health Insurance Corporation. I'll turn the floor over po to Dr. Susie Mercado to introduce our opening remarks speaker.
Okay, so before we go into that, I just wanted to say na I think most of you are observing that there are people who are saying that when they have a heart attack, they can't go to the doctor, or they can't go to the hospital. And I think there was even a report of an OFW who died, had a cardiac condition. And we're wondering now about what's the connection between COVID and heart disease. So we're gonna have a cardiologist as our main speaker today from the premier heart disease hospital, the Philippine Heart Center, and we're all very excited about that. Before I turn over to our introductory speaker, Raymond, people have been asking about certificates.
Yes.
Would you like to give an update on that? Yeah.
Thank you, Dr. Susie. So certificates po, as mentioned, and we have included this in the registration link. Certificates will be handed to those who have been attending at least 50% of the webinar duration. We are just collecting the signatures, and we will be sending the certificates along with the slide decks po for those who have attended the webinars at least 50% po of the duration. Thank you for that, Dr. Susie.
Okay, so for those of you who've been with us for some time, you all know that this is an initiative of the University of the Philippines with the Philippine Health Insurance Corporation. And within the University of the Philippines, there are several units that are working on this webinar. Of course, it's been very important to tap on the resources of the University of the Philippines in the area of medicine. And we are deeply, deeply honored to have with us to give the opening remarks and to share her thoughts on how we can continue to update knowledge and even skills on clinical practice in the field of medicine. So we're very fortunate to have a very, very, very busy person. But she found time to be with us this afternoon, and it's my honor to present the Dean of the UP College of Medicine, Dr. Charlotte Chiong. Charlotte, Dr. Dean, welcome to our program.
Dean, maybe you can unmute yourself po, ma'am.
Well, good morning, everyone. Good noon. Again, thank you, Dr. Susie Mercado, one of the leading figures of the Philippine Health Insurance Corporation. and of course, Director of National Telehealth Center, Dr. Raymond Sarmiento, Gigi Alfonso, Dr. Abad, of course, EVP Herbosa, Dr. Pernia from the UP system side. I'd like to thank you all for giving me the opportunity to share some thoughts about UPCM and COVID-19. I'm not going to show anymore. I'm going to just narrate to you what has been happening at the UP College of Medicine. As you know, since March 11, the classes have been suspended, and we have been on GCQ since March 12, March 16. So we're now about 3 months from the time that GCQ and then became an enhanced community quarantine and then modified ECQ. When I look at the figures, we have like, as of now, if you compare it to April 16, at that time we had about 500 deaths. We have now about 1,000 deaths. 300 deaths at that time, we have 1,000 deaths. So we have 3 times more the mortalities, and we have 5 times more the active cases, because at that time we only had around, I believe, around 4,000 to 5,000 cases. So are we now flattening the curve? If you look at the mortality, yes, it seems to be going down, because it was peaking at around 50 deaths per day at around April 16, and we're now down to around 4 or 5 deaths a day. So it seems that we are getting some headway in terms of being able to manage COVID-19. But what has been the impact on the medical education of our future doctors? Well, to say the least, there's been a lot of changes. We had to shift overnight to online classes. And then we found out by a survey that 30% of our medical students did not have access to stable internet because they had to go home to their provinces. And this has really added on to the mental health issues of our students. So I think we have to be aware that this is not only happening for our university students, it's happening for all types of students all over the country. So if you are going to have some headway on education, basically, and even with virtual learning like this, we need to be able to convince our government to invest heavily on internet services and make it at least affordable. We had to give PASA loads to our students. We're trying to give them around 58 of our students. We need to give PASA loads for 2 to 3 months so that they can pass the requirements. Otherwise, they won't be able to pass the requirements, and the deadline is June 15 if they wanted numerical grades. The university has been very lenient. It's given up to May 2021 to pass requirements if you want a numerical grade. Otherwise, you basically have a deferred grade until then, and you get a drop grade by May 2021 if you don't pass your requirements. So that's been some form of relief for our students. UPPGH during the war was the only institution in UP that was operational. That was in 1946. We consider this as a war. So when the health system was really pressured already and the private hospitals could not anymore handle the number of cases at that time, PGH was called, and it became one of the 3 COVID referral centers. Having said that, we had to ask 1 week to prepare PGH. We had to transform 4 wards into negative pressure wards. We had to call our partner organizations, had to increase the number of PPEs that we had so that we have a reserve stash of around 1,000 basically for 2 months supply. We had to call our UP College of Engineering colleagues. They had to get 17 3D printers going on 24/7 at UP Diliman to be able to have at least 1,000 face shields produced over a matter of 2 days. We had the CBOL, the Surgical Innovation Biotechnology Lab, which had some 30 million funding from government. It has to overnight be transformed to a CBOL COVID task force. And we had about more than 10 projects costing at least more than 100 million for the CBOL alone. And our faculty, who not only had to service the patients at PGH as a COVID referral center, who not only had to teach our medical students and interns because of the online learning classes, had to also do research. And we had about more than 100 researchers needing at least 200 million of funding. And as of now, we're waiting for all the first tranche of funding to come from our government for all this. And these are really relevant researches, looking at the validity of rapid antibody tests, looking at even non-alternative medications like virgin coconut oil as a way to fight COVID. we're in the development of a possible vaccine. We had to transform our classrooms into convalescent therapy, plasma therapy centers. And because people were afraid to go to the hospital to donate their plasma. So having said that, we had to innovate. And I think when we're faced with a crisis like this, innovation becomes of paramount importance. So we had to basically invent some telepresence monitors so that our patients who are poor, who did not have cell phones, who did not have load, could actually have pre-scheduled talks with their relatives in the wards. So that sort of like took away their fears because now they can have some relatives with them. So we also had to repurpose the RX box that was being deployed for maternal and child health to become telemetry stations for our PGH patients. And we had to ask the OST to deploy all these units. And what has been happening is that although there were challenges in terms of learning and alternative flexible schemes for our students, we were lucky because we were preparing for this. As of 1 year ago, we already planned to purchase some of our learning management system. We had a Panopto, so that in October we had that, so that our faculty could actually shift to Panopto to give their lectures. We had the UVLE, and this was Moodle based, and I think UP Manila is now shifting to Canvas. So we're going to level up the learning management system of the university. We had donations for laptops so that our students, even as far as Lagaw, Ifugao, who did not have laptops and gadgets to be able to carry on with their requirements, we were able to send by LBC, donated laptops. So we had about 30 laptops on loan for our students who needed them. And as we're talking, we're trying to procure digital or learning materials like tables and visualizers for anatomy. We're preparing for a robust way of teaching anatomy and physiology, histology to our students. So I think that although there's been a lot of challenges with COVID, we can say that we've been able to really help our students, help our faculty, and we could see the bayanihan spirit had really come alive in UP Manila, in UP College of Medicine, and the whole UP system. During the first week of this war with COVID, we lost a lot of our beloved mentors. In fact, heart disease, cardiology, our cardiology mentors were the first ones to be affected. And this has really fired us up. We had frantic calls to our mentors who were developing local ventilators. So we now have 4 ventilators waiting for safety trials at PGH. So we can see that we have sunny pads, we had transport pads, we had UV disinfectants. So we have a lot of this artillery that we are actually developing up in order to fight this COVID. So we're happy to be able to share this with you, Susie, Raymond, and the rest of the participants in this webinar, because we feel that we're one with the Filipino people. And when UPPGH was called to the service of the nation, we answered yes, and we really prepared for it. And we're happy that we're able to really control the infection rate. We're now testing all the healthcare workers and frontliners at PGH. Of the 20,000 kits that we were able to get as donations, we now have 2 automated PCRs coming over and being delivered by July. And we have 2 centers, 2 testing centers that are accredited within UP Manila campus. That's UPM, NIH, and also MRL at PGH. So we are happy to share. We are really happy to partner with Philippine Health Insurance Corporation. If there's going to be a second series of webinars that will look at how our clinical departments have been able to fight and beat COVID, we'll be happy to share that experience with you. And talking to the department chairs, they're really excited for the second series of webinars with PhilHealth Insurance and of course, National Telehealth Center. Thank you very much.
Oh, thank you very much, Dean Charlotte. Very inspiring message for Independence Day. We're not going to let you off the hook. I'm sure, you said a lot of things that I think are eye-openers for everyone who's listening. Just so you know, Charlotte, there are people listening from Batanes, from Calibo, Aklan, from Quezon, because sometimes they write here where they're listening from. And I think this webinar series has really been an opportunity for the University of the Philippines to reach out to every hospital everywhere, because things are happening so quickly
Yeah.
that we need to be instantaneous also in our ability to share knowledge. And hearing about all the things that you're doing at the College of Medicine, I'm sure there's a lot of interest out there to see how innovation can also be diffused into other medical schools,
Mhm.
other provinces. So I'm quite happy to hear. I mean, we've had some early discussions about having a second phase of the webinar. So I'm very happy to hear that this is something that you welcome.
Yes. Thank you very much, Susie. We're really for it. Thank you.
Raymond.
Thank you, Dr. Susie, and thank you, Dean Charlotte, for that inspiring message po. No? It's, as mentioned po, and based on the old adage, necessity is the mother of all invention. And UP College of Medicine and the Philippine General Hospital have been answering the call since the start of the pandemic. And we are very grateful for all the work that you have been doing. We look forward po to other innovations that perhaps we could share the learnings po to other schools in terms of applying them or for online learning, and then for the other medical schools po in terms of the trainings that will be delivered through this new normal po. Thank you, Dean Charlotte.
Yeah, Raymond, before we go to the poll, again, I don't want to let Dean off the hook on this because we don't get her that often, no? I'm very keen to hear about, and I'm sure those who are listening to us are keen to hear about research,
Yes.
and that UP College of Medicine and Philippine General Hospital is doing a lot of research. Right now, do we think that we are soon going to be able to come up with our own, what should I say, conclusions about treatment,
Mhm.
management, diagnostics, and so on? Because we were so dependent on
Yeah.
testing coming from abroad. We're
Mhm.
dependent on supplies. You mentioned a little bit about vaccines. So could you just say a little bit more about that? Because it's Independence Day. I think it is an opportunity for us to envision our own independence in terms of being able to fight COVID.
Yeah. Thanks, Susie. Actually, tama yan. We have to be independent. And we started off by first when Wuhan and came up with the genetic sequence of the virus. We started working on that. UP Manila researchers led by Dr. Raul Destura started working on developing a locally available RT-PCR test. And when GCQ was actually announced, we were already at the point where these have been prepared and validation was already ongoing. And as we speak, before we had the field implementation at PGH and other hospitals. And this has been found to be very accurate, comparable to most RT-PCR kits abroad. There was a glitch in that there was one batch that had contamination that was clearly recalled right away. So in terms of testing, I think we are able to ramp it up. The goal is to be able to come up with 10,000 test kits every day. So I think that was the goal. And the goal of government was to come up with at least 20,000 testing every day, even up to 30,000 tests every day. We are aiming to have 2,000 tests at UP Manila, NIH, and PGH MRL. And with the PCR automated machines, we should be able to even ramp it up more. There are vaccines. We have a group now looking at some vectors and being able to have some products or parts of the virus and find out whether we can develop some form of defense against that. So that will be the core work of a possible future vaccine center that will be led by UP Manila. We're hoping government will anoint us as one of the leading centers for vaccine production. The first thing that we'll do is to have all the experts talk about, can we do it? Is it something that economically we can afford? Because vaccine production does need a lot of funding and commitment on part of government. Or should we just focus ourselves on the safety trials of the vaccines or some form of monoclonal antibody production, for example? So we're looking at that, and we have the experts, expert researchers at UP Manila. Aside from that, we have innovators. We have people from the surgeons are trying to innovate in so many ways in terms of sanipad. Itong mga misting na to na may namatay, we're trying to look at a safer way. We're actually working with UP College of Engineering for UV cabinets para hindi masyadong magastos ang pagbili ng mga PPE. We're working with College of Public Health para malaman kung effective ba itong mga sanipads na to na gagawin natin for distribution nationwide. So we need to really be self-reliant, not only in terms of testing, but in terms of prevention, which is vaccine, hopefully, and treatment. The protocols of WHO that we followed, hook, line, and sinker, came out to be not really applicable for us. As I was talking to Dr. Camilo Roa yesterday, we don't need as many ventilators now because high flow oxygen can work. We now know that we have to give the convalescent plasma earlier than usual. We also know that some of the prophylactic antibiotics that were being given are not really that effective. So we're in the process of validating all the different information that WHO has been giving us, and we are actually exerting all efforts to validate all the information and the protocols that are being asked of us. And we are part of the WHO Solidarity Trial. And we hope to be able to also have our share of the knowledge being produced in terms of treatment for COVID. So nandun po tayo mga kababayan ko, ang UP College of Medicine, ang mga doktor po rito ay mga researchers din. At kami po ay nangunguna sa paghanap ng talagang solusyon para dito sa ating COVID dito sa Pilipinas. Alam natin na maaring iba ang ating reaksyon sa mga gamot, iba ang ating reaksyon sa mga ganyang mga gamot at management. Kaya po, pinag-iigihan po natin na malaman ano ba talaga ang totoo, ano ho ba ang talagang applicable sa mga Pilipino tulad natin.
Yeah, okay. Thank you again so much, Dean Charlotte. I think
Thank you.
a very strong message for Independence Day that we are, on our own. We're looking exactly, we're researching, and we're going to find out what's best for the Filipinos. So, again, it's Independence Day. I think I heard, is it correct? Were you celebrating your birthday yesterday?
Yes, yesterday was my birthday.
So ano ka pala? La Independencia pala.
Thank you.
Happy birthday, Dean Charlotte. And
Happy birthday, Dean.
Thank you so much. We know you're very busy. If you want to stay on the webinar, it's fine. But if you need to leave, it's also okay. But I think you've given us really a good chunk of time, good insight, and a very powerful vision for everyone who's on the webinar. So maraming salamat po. Thank you.
Maraming salamat, Susie. Maraming salamat, Raymond, and all the rest of the team. Thank you.
Thank you. Thank you.
Thank you, Dean, for spending time with us po. And it's a holiday, ma'am. Maraming salamat po.
It's really my pleasure. Salamat. Maraming salamat.
Okay. Thank you po. Raymond, are we going to start with your poll questions first before I
Yes.
the speaker?
Yes.
Yeah. Go ahead.
Thank you, Dr. Susie. I think this is the time wherein we do our fun quiz before we start with our presentation proper po, no? These questions came from our resource speaker, and the correct answers po will come from our resource speaker po towards the end of the webinar. I think we have two questions here. The first question reads, aside from lymphocytopenia, which cardiac biomarkers have good prognostic value in COVID-19 infected patients? So please join our pre-webinar questions po. I think the answers po are slowly trickling in. Most of our attendees po. So we have four options here. Option A is CKMB. Option B, troponin I, option C, D-dimer troponin I, and option D, NT-proBNP. Most of our attendees po they are clearly gravitating towards option C, and we will ask our research speaker po if that really is the correct answer. For our second question, it reads, this is said to be the most common mechanism of acute coronary syndrome among COVID-19 infected patients. We have four options po ulit. Option A is type 1 MI. Option B is type 2 MI. Option C is viral cardiomyopathy. And option D is acute pulmonary embolism. So medyo neck and neck po ang ating mga attendees between option C and option D. And we look forward to receiving po the correct answers from our research speaker who will right now be introduced by Dr. Susie Mercado. Dr. Susie?
Yeah, thank you very much, Raymond. I think for most of us, when we first heard about what was happening in Wuhan, one of the things we heard was that individuals with hypertension or pre-existing comorbidities of the heart were very high risk for actually severe COVID and for death. The first time I heard Dr. Permejo speak, our speaker is Dr. Chito Permejo of the Heart Center. The first time I heard him speak was in a Zoom meeting with Dr. Roa, and he's an intensivist. No? So he has been at the front line working with critical care patients and looking particularly at heart cardiovascular disease and COVID-19. And he was saying that you could actually, keep the patients alive by very close monitoring using 2D echo and other things. And so I thought, at some point in time, we need to invite him to speak, because this is, 1/4 of all Filipinos have hypertension. And I don't know how many, a big chunk of Filipinos also have some form of cardiovascular disease. And so when you have a pandemic like this, then you have a high risk based mainly on the epidemiology of cardiovascular disease. So it's my honor to present Dr. Chito Permejo, who is an intensivist at the Philippine Heart Center. And before he makes his presentation, we just wanted to introduce him. Chito, welcome to the show.
Hi, ma'am.
To our webinar.
Good afternoon, ma'am. Good
Hi.
afternoon, everyone. Happy birthday, Dean.
Yes,
Yeah.
thank you very much. So, Dr. Permejo, how many COVID patients do you have at the Philippine Heart Center now?
Um. Actually, actually, ma'am, I don't have the exact number as we speak now, but the total that we had, counting from suspects to confirmed, is about 240 plus. Around 90 of these are confirmed, but it's basically yung magnitude of care is basically the same whether they're negative or not, no? Because the policy has evolved into something like parang open to everyone and treat everyone as positive as they get admitted, no, in general. So the magnitude of care did not really win, no, from the start, no, of the epidemic, at least in our institution, and it's been evolving, hopefully for the better management of our patients, no, particularly our cardiac patients in the Philippine Heart Center. They're kind of different in a way that around 90 to 95% of these patients are really cardiac patients. So not just simple hypertensive patients, but patients with congenital heart disease, patients with valvular heart disease, and most of these have coronary involvements, no, who in the past have had revascularization procedures or presently being admitted for acute vascular events. No.
Okay. So, Raymond, did you have any questions for Dr. Permejo before we start?
So, Dr. Chito, is
Hi,
yung
Raymond.
rate po, good morning sir, yung rate po ng let's say of infection, at least in the Philippine Heart Center, is that really on average po for other hospitals that are non-COVID referral hospitals? Is that something that, let's say, if I'm a business owner or something of that sort, that will be an expectation for hospitals that are non-COVID po, referrals, yes, hospitals po?
Okay, so first of all, Philippine Heart Center is really not a referral center for COVID. It
Yes, sir.
just so happens that our sets of patients or subsets of patients are very sensitive with COVID. The manifestations are actually dramatic, no? So when they get in, the rate I think will be a little less as compared to the other institutions like Medical City. So I believe they were receiving like hundreds of patients, no, as compared to how we were receiving these cardiac patients from the start, no. So I guess it's a little less, but uh, uh, like what I've been saying a while ago, the magnitude is a little different because a lot of these patients are getting admitted to the ICU, no? So with a simple cough, no, the next day you'll just find them toxic and ICUable. No, so we really have to step up, no, with our management, step up with our triaging at the ER, and it's up a lot of resources, no, because we also cater to charity patients. So we, yeah, that's it. We need to step up with regards to how we clear this patient or how we admit this patient in terms of ordering for diagnostic procedures, and at the same time being careful with the medications that we're giving, because these are cardiac patients and most of these patients would already have other organ involvement like kidney failure. So it's basically the nuisance of taking care of our cardiac patients. So other non-cardiac patients, I guess they don't necessarily go to heart center. No? So other institutions would I guess cater to them. Like St. Luke's also had, a great number of patients getting admitted. The medical city and other government hospitals, like of course, PGH and Rizal Medical, no, if I'm not mistaken.
Well,
Okay.
hopefully,
That's
Sir
it.
Chito, it's the proportion of infected healthcare workers po hindi po tumataas or at the very least bumababa naman po siya, sir. Okay po.
Yeah, yeah, yeah. Hopefully, we also have the same experience with our healthcare workers. So hopefully, we stop, no, these transmissions within the institution because we really need them for
Okay.
our
So,
patients.
so Dr. Chito, I think
Yes, ma'am.
everyone's excited to see your slides and to hear your presentation.
Yes,
So
ma'am.
we can go into your presentation now. Let's
Okay, po.
cue the PowerPoint. Here we go.
All right. Do you see that, ma'am?
Yeah, go ahead. Go ahead. The floor is
Yes.
yours.
Okay. So I'll start now. All
Yes.
right. Okay. So first of all, I would like to greet everyone. Happy Independence Day. I hope you're all enjoying your our little vacation now for today. And second of all, I would like to thank, of course, Dr. Susie Mercado for inviting me and the rest of the organizers, of course, Sir Raymond from the National Telehealth. And I would also like to thank Dr. Chiong for sharing her time. Let me also congratulate and commend her for all her efforts, no, for our kababayan. I'm really one very proud alumnus, no, of the UP College of Medicine. I actually belong to the College of Class of 2001, the 2001 batch. All right, so I'm actually tasked to hopefully share my humble insights as to how we manage cardiac patients, no, because for me these are very special patients, no, that among the different set of patients that we cater, no, having these comorbidities that make them very vulnerable to catastrophic progression of the disease. So this is COVID-19 and the cardiovascular implications. So with this slide, I hope I don't get to offend, no, anyone. Hi pala sa mga kababayan natin sa iba't ibang probinsya. The Rashomon effect. So I just came across when I was reading this thought about the Rashomon effect. So for me personally, it's basically the how we can better describe what's happening right now. And it was reassuring that Dr. Charlotte Chong was mentioning about the ongoing research efforts by the UP medical community with regards to diagnostics, perhaps treatment, the testing, etc. Because this Rashomon effect basically is it describes a situation wherein we have contradictory interpretations, no, of different individuals involved. No? So different researchers, medical practitioners would have different interpretations of the causality, the clinical course, no, and possible predisposition of our patients. But we are all looking into one disease entity. And personally, I think we are good with the last article, no, or the last journal that we read about COVID. And but we're still all still learning, no, and our knowledge of COVID is, I think, is still evolving, and but hopefully for the better understanding of our needed safety, no, against COVID, and the efficacy of the different treatments, no, we render our patients, no. So as what is outlined, no, in this slide, no, I hope or I aim to discuss, no, the following as outlined in the slide, no, of what we may already know or what we already know about COVID, the the link, no, between COVID and the heart, no, which you'll soon later realize is the ACE2 receptor, or the angiotensin converting enzyme to different cardiac involvements, no, and highlighting a little some of the different cardiac events that are most commonly found among our COVID patients, no, acute coronary syndrome, those having hypertension as part of the manifestation or part of the comorbidities of these patients getting admitted, patients developing palpitations, and eventually arrhythmia, no, which can be fatal, no, at some point in time during their admission. I'm really not going to dwell on the therapeutics because it's parang a whole new set of story altogether. But perhaps we'll just focus on what I think personally should be the mainstay. And at this time that there are no confirmed or uh, confirmed effective treatment, I think what our kababayans or what the medical community should be focusing on would be strengthening the supportive treatment to our COVID patients, whether cardiac or non-cardiac. And at the last stretch of my lecture, will mention some key considerations and recommendations to our cardiac patients or our patients who develop cardiac complications, and perhaps answer why is there a greater risk, no, of events, no, and why are there patients, no, with greater complications during this pandemic. They're all basically expected, no, or very common, and they were consistent, no, with the different studies. So as of last yesterday, there's about 7,255,960 confirmed cases of COVID-19, including 412,583 deaths as reported by the World Health Organization. So that's really something. And in the Philippines, uh, here, so we already have 43 23,732 confirmed cases and about 1,027 deaths. This is as of yesterday. So with about 10 new deaths, no, and about 740 new cases. Uh, this particular slide will actually give you more or less a picture of the different mechanisms of uh, COVID-19 and how these cardiac complications come about. So alongside these different mechanisms, if you notice, will be uh, pro-inflammatory cytokines. So mention of inflammation, so which is very much predominant. But other mechanisms would involve direct vascular infection, no, systemic pro-inflammatory stimulation, which best describes your cytokine storm. The proclivity of these patients to develop hypercoagulable state, sympathetic stimulation, basically that's expected, especially for critically ill patients, the imbalance of oxygen supply and demand being brought about by acute respiratory distress syndrome, most commonly, of course, being brought about by lung infection or bacterial infection, and also involves direct damage to the myocardium, no, affecting the myocyte and the pericyte, creating necrosis and eventually creating fulminant myocarditis or heart failure, and eventually, having this part of the damage would be the development of arrhythmia. So these three are basically the more common ones that we see, at least from the Philippine Heart Center, where I actually am part of the strike team. No? So we call it the strike team in the Philippine Heart Center. So we're actually composed of uh, two intensivists, no, cardio-intensivists, then two pulmonologists, and one infectious disease. And we actually call different subspecialty for support, no, whenever there's the need arises, no, for some organ failure. All right. So what you see from this slide are are not flowers, no? So they're not even corals, no. So I'm just wishful thinking that I'm in the beach, no. So they're not corals. You what you see are interleukins, no? So they're cytokines or inflammatory mediators attached to these different receptors, no. So in a sea of cell membrane. So in a nutshell, what I would like to emphasize is this particular infection, the COVID-19 infection, is parang a short course for Immunology 101. So it's basically inflammatory in nature. So let's not fault the heart yet, because this is one mechanism that aggravates, no, the existing cardiac problem of all our patients, even for a simple hypertension. So basically, uh, just like any other disease, COVID-19 infection basically follows the tenet, no, so of acquiring diseases. No? So it goes on different stages, and the acute disease progression can be divided into three distinct phases. So you have the early infection. COVID particularly would have the pulmonary phase and the hyperinflammation phase. No? So in any given patient, however, there can be a significant overlap, no, among these phases. No? And although most cases are mild or asymptomatic, no, so I think in the literature it was consistent that it ranges from about 75 to 80% of the time the patients would come in with mild symptoms or even asymptomatic. No? So this paradigm of disease progression, especially with critically ill patients with COVID-19, really highlights, no, the role of inflammation and secondary organ involvement. So the moment inflammation sets in, we should all be on guard, no, for protecting the other organs, most particularly the heart. No, so during the early infection phase, no, the virus infiltrates, no, the lung parenchyma and begins to proliferate, so creating this, at least initially, mild constitutional symptoms, no, and marks the initial response, no, by the innate immunity, particularly your monocytes and macrophages. So if you will read on these different articles, you will consistently see, as part of the inflammatory markers, no, the contribution of monocytes and macrophages alongside your different interleukins. No? So that's how bad our inflammatory response is. No? So this innate immunity. So with inflammation, you see collateral damages, no, collateral tissue injury, and the inflammatory process that follow, no, which would include vasodilation. So most of these patients are relatively on a hypovolemic state or hypo or a vasodilated state. No, so we should be careful with onset of hypertension. I mean hypotension, and most of these patients, because of inflammatory process, it expect endothelial dysfunction, no, or increases in permeability, no, of the cellular membrane, or even lung permeability for that matter. No? So you'd expect leukocyte recruitments, no, in these different organs, no, except from the immunologic organs themselves, no, which leads to further to the pulmonary damage itself, no, creating hypoxemia, and of course creating cardiovascular stress. No, so in a subset of patients, no, the host inflammatory response continues to amplify. No? So parang geometric amplification, especially if the supportive treatment is really not adequate. And this goes on even with decreasing viral loads, no, as we go by, no, as the days go by. So and results in systemic inflammation. So this systemic toxicity would actually in turn alerts you to the development of organ failure. So I would like to share some slide on, yeah, this one. The CT scan is one. This CT scan is actually a very good illustration of a CT scan finding of a patient with COVID in its initial stage. So you can see consistently the peripheral distribution. So actually, a lot of literature would say that it's mostly peripheral, no, in distribution involving the right. But I've been seeing literature involving bilateral lung involvement, no, the literatures that I'm seeing right now. So it's bilateral, described as bilateral, multifocal, and predominantly peripheral ground glass opacity. So this is more commonly seen among asymptomatic or mild patients. No, so it's different when you actually see one that has full-blown no, lung involvement. So as the disease progressed, no, lesions are now bilateral, still bilateral. Of course, they're multifocal, and you see ground glass opacities, which is distinctly described as crazy paving. No? So when they actually described it, that's mostly typical pneumonia or typical lung involvement seen among COVID patients. Other theories, although debatable, would be the involvement of COVID-19 with the damage of the hemoglobin itself. So there's a noble study by a Chinese investigator, no, suggesting that SARS-CoV-2 may have the ability to dissociate iron from the porphyrin and bond with the porphyrin itself. So the alteration in the hemoglobin function, as the investigators would claim, no, can be the cause of the additional lung damage and the respiratory distress. So aside from the hypoxemia, it's the damage to hemoglobin, which carries the oxygen, of course, that adds up to the stress, both for the lungs and the cardiac. However, this has been highly contested. So recently, there's a claim no of a certain Wenxiong and Walan no published just recently, and the results of their study mentioned that in the production of the structural proteins, now both for structural and non-structural proteins, now one of these non-structural proteins invades the hemoglobin, removes the iron atom, and binds to it, no? So preventing oxygen expectedly from being carried. So this would explain the rapidly evolving hypoxia picture. And just like the previous CT scans that I've shown you, no, largely reflect the degree of hypoxemia or hypoxia no, that this COVID-19 virus no, is giving our patients. So within this framework of acute disease progression, no, lymphocytopenia no, is a prominent feature and is associated with adverse outcomes. So I think this has something to do with the first question no, that was posted a while ago. So the higher proportion of non-survivors, as you can see the red line here, and critically ill patients with COVID exhibit progressive lymphocytopenia. So it doesn't really die down, at least for the first 7 to 14 days. No, kung hindi pa namamatay ang pasyente, you'll see persistently lymphocytopenic patients, and not only the capacity of direct leukocyte infection, but also a relative predilection for lymphocytes. So there's over 50% as manifested in this electron microscopy study. No, 50% of lymphocytes actually harboring no, mga viral inclusion, harboring these viral particles, and most of these were actually T cells. No? So this suggests a high vulnerability of lymphocytes to viral infection and destruction, and persistent destruction at that. No? So the same study would also point out to decrease in the level of the CD4 and the CD8, which is actually a good marker of the immune status of the patients that our colleagues would actually monitor no, with regards to their response no, to a certain infection. So this exaggerated systemic inflammation no, or cytokine storm as the disease progresses may correlate with lymphocytopenia again, and is basically the hallmark of severe disease. No, it represents an advanced stage of acute illness with multi-organ failure. No, most notably kidney failure and liver failure at some times, and elevation of these different biomarkers, no, namely your interleukin 6, 2, 7, or 1, no, your tumor necrosis factor, your interferon gamma, your monocyte and macrophage proteins, your CSF or colony stimulating factor, your procalcitonin and ferritin, which are also good prognostic markers, no, and inflammatory markers that we monitor, no, in the heart center, or part of the different inflammatory markers that we monitor. However expensive, no, but all for the better management of the patient. So in this retrospective clinical series, no, the non-survivors exhibited higher levels of IL-6, no, so the red one, and high levels of serum ferritin. Now, serum ferritin being consistent with regards to if you want to determine lung permeability or the inflammatory process, ferritin is a good, sensitive, and specific marker for that. No? I actually asked that a lot, no, from the cardio fellows or from the fellows who takes care of our patients no, in the Philippine Heart Center. Always include the ferritin because that can actually give you some signs as to how bad the lung is, no? And consistent with this notion of biomarkers of cardiac injury increasing, no, and some electrocardiographic abnormalities like ECG changes, no, it correlates well with the elevated inflammatory markers. And this represents an indirect mechanism of cardiac injury. So if you have elevated cardiac troponin on the background of an IL-6 increase and a serum ferritin increase among other inflammatory markers that are being requested, no, for our patients, both inside of the ICU, then that can be a sign that sometimes we need to step up in our management and monitor this patient very well or more frequently. So let's discuss that a little later. So as I've said in the introduction, the hypothesis of how COVID brings about this particular problem is multiple, no? And it actually grows in number every day as we discover new things. Okay, so what's the link? A lot has been said about ACE2. In fact, nasiraan na ang ACE2, no? So many bad things being said about ACE2, and people having that misconception of holding these different antihypertensive medications just because of this particular concept of ACE2 and how this contributes, no, being the entry point of the COVID infection. So what's the link between COVID and the heart, no? And that can be answered by the role of their ACE2 receptors in the transmission of the disease. It's actually our carboxypeptidase receptor that converts your angiotensin 2 into angiotensin 1. So a little physiology, no, with this regard. Okay, so this enzyme is homologous to the actual ACE, which is the main pathway, no, for our hypertensive medications, no, with regards to control of our hypertension. So the ACE2 basically serves a counterbalancing role, no, in the renin angiotensin aldosterone system. It's actually good to have this ACE2. Okay, so however, it's a requirement for, it's a functional receptor and a requirement as a portal of entry for both SARS-CoV, yung mga previous epidemics pa natin before sa Hong Kong, the SARS, no, and the MERS, no, and of course the SARS-CoV-2 nowadays, no. So remember, the ACE2 is an ACE2 receptor, carries a good name, no, until this coronavirus came. So okay siya until dumating si COVID. Okay, just a little physiology so we can further understand why ACE2 is actually the link between the COVID and the heart. ACE2 is a transmembrane protein, okay, comprised of these different domains. No? So you have the glycosylated N-terminal domain, no, containing your carboxypeptidase, no, and a short intracellular C cytoplasmic tail. So this N-terminal peptide domain, or what we call the S1, no, and the S2, is also the SARS-CoV binding site. So as you can see from the illustration. So there are actually two forms of ACE2 protein. You have the cellular or the membrane bound, or the one that is within the membrane or the transmembrane form, and the one that is circulating or the one that is soluble. So membrane and soluble. So the cellular ACE2 basically is the full-length protein which is expressed abundantly in pneumocytes and enterocytes. So you'd expect these manifestations of cough, no, and diarrhea to be really predominant, no, among our COVID patients. That's precisely because of their preponderance, no, in these particular cells, no, the pneumocytes, the lung, and the intestines, no. However, ACE2 is also expressed in a lot of other organs, no, and that includes the heart, the vascular endothelial cells, no, of the heart, even the kidneys and other organs, such as the brain, no. So sometimes you'll see studies of the possible trophism of COVID-19 in the central nervous system or generally in the nervous system. So the circulating ACE2, the one that is being cleaved, no, as you can see from here, from the full-length ACE2, with the metalloproteinase ADAM17. So this ADAM17 is the one alongside your TMPRSS2 are the two particles that actually is responsible for the metabolism of your ACE2. No? So the type 2, the ADAM17 actually metabolizes the ACE2, so it cleaves off the S1 domain, and this one will basically, in a normal homeostatic environment or milieu, no, will exert its anti-angiotensin 2 signaling, so opposes the vasoconstriction and gives its homeostatic functions. And this particular receptor is basically the only receptor that is required for the portal of entry. So yung TMPRSS2, no, which is actually results in augmented SARS-CoV cell entry. So without this, the SARS-CoV can't actually possibly enter. So there are actually two ways to enter the target cell. The first one would be endocytosis, no, as how you can see from the illustration. And the next one would be just a simple fusion, no, in the membrane. And this one is the one that is highly magnified or is 100 times more efficient as compared to this. No? So as the N-terminal domain, excuse me, in the coronavirus binds, no, the circulating is to also binds to the virus. So aside from going into the other organs, so it binds to the virus present at that particular membrane. Okay, so what's interesting with the TMPRSS2, no, is based on my research is it's expressed in a large population of epithelial cells, particularly the prostate, no? Also the colon, some areas of small intestine, the pancreas, the kidney, the lungs, and the liver, no? And this is upregulated by androgen. Eh, saan ba natin po makikita ang androgen? So, syempre, it's a male sex hormone, and we expect to have predominance of androgen, of course, among our male patients, no? And this somehow, as what they would suggest, contribute to the infectability, no, of the host. No? So there's a recent clinical study who reported that among COVID-19 patients, inpatients, 62% were male, and among non-survivors, 70% were male. No? So it's a little, the picture is a little similar with what we have, no, in the Philippine Heart Center, with what male preponderance. All right. So going to some of the studies, which I will subsequently mention from now on, this is what I saw in one of the articles I reviewed. No, there's this particular study involves 191 patients from a certain hospital, which is the Jin Yen Tan Hospital, 135 of them, and 56 from another hospital within Wuhan, or the Wuhan Pulmonary Hospital, no, were included in this study, of whom 137 actually survived or were discharged, and 54 died in the hospital. So 91%, according to the study, would have comorbidities, and the predominant comorbidities would be the following. So it's your hypertension being the most common at around 30%, followed by diabetes, and your coronary heart disease is about 8%. No? And a multivariable analysis or regression analysis from this study would show increased odds of in-hospital death associated with older age, no, older age, and those who have pre-existing coronary heart disease. So uh, aside from that, analysis was also made on some risk scoring, and were found that those patients who have higher SOPA score, no, if you actually practice in your ICU uh, with regards to prediction of the prognosis of the patients. So among the patients who were admitted, the high SOPA score and the high levels of D dimer, no, greater than 1 microgram per liter on admission would somehow predict, no, the course, or the clinical course of the patients getting admitted. So this particular study also studied the median duration of the viral shedding, no, which was about 20 days, no, at least for this study in survivors. But SARS-CoV-2 DAO was detectable even until death, no, in the non-survivors. And the longest observed duration of the viral shedding in survivors was about 37 days. So aside from the comorbidities, the potential risk of older age, no, as I've mentioned, the high SOPA score, no, and the D dimer greater than 1 microgram per liter could also help clinicians, no, just every one of us, of course, identify patients early on with poor prognosis, no, at an early stage, and prolonged viral shedding, which can provide rationale for some of the policies, no, or strategies of isolation that is being implemented, no, especially on infected patients, and the optimal antiviral interventions in the future. So okay, so what is really the function of the ACE? No, so just a little going back to the function of the ACE. No, so ACE, as I've said, is homologous to ACE. No, so it's as is well known, ACE cleaves your angiotensin. No, so if we talk about hypertension, the RAAS pathway, no, the ACE cleaves your angiotensin 1 into your angiotensin 2, and this binds to your AT1, no, predominantly in more than 90%, no, of its function basically will be focused on AT1 receptor that mediates numerous local and systemic effects like vasoconstriction, fibrosis, salt retention because of aldosterone secretion, and of course autoimmune, no, autoimmune functions. So AT2 would actually serve vasodilation. So in the RAS, the ACE2 exerts the opposite role of the ACE. No? So ACE2 basically catalyzes the conversion of angiotensin 1 also into an angiotensin 1-9, and the conversion of your angiotensin 2 into an angiotensin 1-7. Okay, and this angiotensin 1-7 basically binds to the mast receptor, no, of the vascular endothelium and different tissues that would be responsible for the positive homeostatic functions, no, of the ACE2 particularly, no, like vasorelaxation, cardioprotection, antioxidant property, antifibrotic property, anti-inflammation, and anti-angiotensin 2 induced signaling. So it basically counterbalance the function of the ACE, no, in its conversion of angiotensin 1 to angiotensin 2 in the angiotensin 1 receptor. So what's the implication? So let's go to the next slide. So a large cohort of study, which I basically saw in this particular study, showed that circulating ACE2 was only detectable, in the serum of 40 among 300, 530 or 560 test subjects. And its concentration was approximately 100-fold lower than that of the circulating ACE. However, more evidence showed that circulating ACE2 is increased, naman, in patients with type 1 or type 2 diabetes. So those with comorbidities like diabetes will be most likely be the one that is hardly hit, by this preponderance of ACE2 amongst them. They're also seen to be uh, predominant, among hypertensive patients, also heart failure patients, and even chronic kidney disease patients. And the reason for the increase in the ACE2 allegedly in these patients is that increased ACE2 is basically a defensive response to vasoconstriction and inflammation. So there's upregulation because of the inflammatory process going on. Thus, the link between SARS-CoV-2 and ACE provides a very good theoretical mechanism for cardiac dysfunction in COVID-19, particularly those with comorbidities like hypertension, diabetes, and heart failure or coronary artery disease. So this ACE2 downregulation leads to cardiac dysfunction because they're being used up by the COVID. So in addition, the relationship between viral entry and ACE2 forms the basis for the controversy, surrounding the use of the RAAS, or the renin-angiotensin aldosterone system antagonist, which increases the ACE2. But even the directionality of the effect, is actually being debated. So there's no final conclusion as to whether you should really stop these antihypertensive medications. And I think different societies have come up with their statements on that. But before that, I just like to mention that with the common thread, of obesity, being among the different comorbidities present among our cardiovascular patients, attention has also, attention has been expected, no, uh, expectedly turn to the role, of the adipose tissue in the development of type 2 DM and hypertension, and eventual contribution, to the complications of the COVID-19 infection. So that's really expected. So we know for sure that studies have been made about the adipose tissue, and they're already recognized as an autonomous, endocrine system. They're endocrinologically active tissue that also expresses components of the RAAS, including the ACE2, and has its own local RAAS that is involved in the regulation of the blood pressure. So imagine a hypertensive patient, diabetic patient, and some of these patients getting obese, with all these ACE2 receptors all around their body. So this adipose is an acknowledged endocrine organ on its own. So adipose tissue produces adipokines. So as you can see from here, that sends signals to many organs, to maintain their basic metabolic functions. But it is when these adipocytes, especially from the diet, and our own endogenous production, of these adipose tissues, that it becomes, as they say, an angry fat. So it's a term for adipocytes. Now, not only to produce increased amounts of adipokines, but they undergo excess unregulated lipolysis, leading to increased circulating free fatty acids that basically facilitates these disorders that can in turn potentially into the development of the complications that we are seeing now with our COVID patients who are that are patients who are infected with COVID. So again, there's another clinical data showing that among COVID-19 patients, about 30% have underlying diseases. And these patients have increased risk of death. So hypertension was the most common, followed again by diabetes and coronary artery disease. No? And since the angiotensin 2 81 axis is hyperactive, no, in these particular diseases already. So you could expect that the SARS-CoV-2 will further decrease the production of the functional ACE. No? So therefore, in patients with those underlying diseases, it is much easier to develop severe and critical conditions, at least from these different articles that I was able to read, no, and analyze. So there's a large multi-center prospective study of newly diagnosed hypertensive patients. So this is the PAPI study, the primary aldosteronism prevalence in hypertension study, which addressed the relationship between BMI, obesity, aldosterone, plasma renin activity, and aldosterone-renin ratio. So this study involved about 1,200 patients, hypertensive patients, and there was really a positive correlation between BMI and plasma aldosterone, independent of the age of the patient, the sex, the blood pressure level, or even the sodium intake, among these essential hypertensive patients. So the association was stronger in patients with overweight and obesity, so thus suggesting a pathophysiologic link between aldosterone production, obesity, fat deposition, and this allegedly these different complications that we are seeing. Again, to answer with regards to the anxiety of the people with regards to the use of antihypertensive medication. So different societies, and one of them would be a joint statement of the Heart Failure Society of America, ACC, and AHA, releasing statement with regards to the use of RAS antagonists. So it says that currently there are no experimental or clinical data demonstrating beneficial or adverse outcomes with background use of ACE inhibitors, ARBs, or other RAS antagonists in COVID-19 or among COVID-19 patients with a history of cardiovascular disease. So they also recommend still continuation of RAS antagonists if with indications, for those patients who are currently prescribed, for which these agents are known to be beneficial, such as your heart failure, hypertension, or ischemic heart disease. The treatment should be individualized according to each patient's hemodynamic status and clinical presentation, which makes sense. So basically, if you still have the indication, patient hemodynamically stable, presenting with hypertension, so the recommendation is to still continue, and except for some patients who will show signs of deterioration, hemodynamic instability, basically, which is what we're doing in the Philippine Heart Center. So any signs of or red flags that will help us or tell us that this patient is deteriorating, of course, we will definitely hold these antihypertensive medications and not just the RAS blockers, because the washout period for these long-acting medications takes a little time. No? So we'll be proactive, and perhaps just like you guys, if you see those signs, then you can discontinue anytime. So just continue it if indications, if contraindicated, by all means, discontinue it. All right, so cardiac involvement. So cardiac involvement, at least at the level of the cardiac biomarkers or a biomarker elevation, is basically a prominent feature in COVID-19. And it is actually associated with worse prognosis. Going back to the study I've showed you a while ago, for example, so patients with adverse outcomes, including ICU admission and mortality, had significantly higher levels of cardiac troponin I, or cardiac troponin T, or cardiac troponin I, especially the highly sensitive, the HS troponin I. So there's actually a steep rise observed to be happening around 2 weeks. So once you see patients around this time, there will be actually a steep rise in the level of the troponin I, and rising steadily over the days. And this is consistent with what have been shown in the other studies, that the full manifestation of the cardiac injury was generally observed at day 14 and beyond. Especially after the sepsis and ARDS, which onsets signaling the connection of the severity of the inflammatory process and the possibility of an indirect cardiac injury. Again, I would just like to re-emphasize that at least from these studies, showing you the steep rise of the troponin I around 2 weeks of hospital admission, and this particular study showing acute cardiac injury based on parameters that will tell them that that really is an acute cardiac injury based on biomarkers and perhaps echocardiography or ST changes or ECG changes, now you can see that it's preceded by an inflammatory process in the form of sepsis and ARDS. So a lot of inflammation going on before you expect the acute cardiac injury to be full blown in COVID-19 infected patients. So in this study of the characteristics and outcomes of 21 critically ill patients with COVID-19 in the Washington state, so the other part of the globe, okay, the beta natriuretic peptide levels were also elevated among the ICU, admitted in this particular Washington hospital. And they appear, at least as what this study would say, to be more universal than the troponin elevations. But it's still unclear whether the high rate of the cardiomyopathy among these patients in this case series reflects a direct cardiac complication of COVID-19 or resulted from an overwhelming critical illness or inflammatory process. So this is basically showing you again the comorbidities or the baseline characteristics of these patients to be predominantly congestive heart failure. They're actually a small case series, but mostly were found to have congestive heart failure and diabetes. And then again, just re-emphasizing the consistency of the absolute lymphocytic count or lymphocytopenia among these patients and the predictability of this result in tracking the course of the patient as they get admitted and eventually gets worse in their clinical presentation. All right. So furthermore, among the causes of death, again, this time in a Wuhan cohort, the myocardial damage and the heart failure contribute to, and when combined, to 40% of deaths, either exclusively or in conjunction with respiratory failure, and is tracked basically by a very high levels of high sensitive cardiac troponin. So in an adjusted Cox regression analysis of this same study, also published, published in JAMA, patients with elevated circulating cardiac biomarkers of cardiac injury were also significantly at higher risk for death. So comparing the different outcomes. So in this study, surprisingly, the mortality risk associated with acute kidney injury was more significant than age. So I think this is just one of the very few studies wherein this particular result is presented this way. So uh, the mortality risk associated with acute cardiac injury was more significant based from this study, more than the age, the presence of diabetes, COPD, or even prior history of cardiovascular disease. So thus, cardiac involvement is this is just saying that cardiac involvement is really prevalent and apparently prognostic in COVID-19. So nevertheless, little is still known regarding the incidence of genuine clinical manifestations of heart diseases. So biomarker elevations may simply reflect systemic illness in a large fraction of critically ill patients with COVID-19, or it might just be an acute vascular event, but we cannot really know unless the design of the study was set to establish a cause-effect relationship. So even eye cardiologists would have a hard time distinguishing which one is an authentic, simple cardiovascular involvement or basically brought about by COVID-19 infection. So in this study of patients who died from COVID in one of the 5 centers in Wuhan, who accepted and managed these patients, there was a significant difference in the age, and between the death group and the discharge group, but there was no significant difference between the two sexes, between males and females. So the survival time of the enrolled patients was also analyzed in the death group, and the distribution of the survival time from the disease onset to death showed two peaks. The one with the first one at approximately 14 days, around 22 cases, and the second one at approximately 22 days. So I think in our local setting, some of these presentations are also being manifested. So laboratory results in this particular study on clinical predictors of mortality showed that there were significant differences in the white blood cell counts, absolute values of the lymphocytes again, and some other parameters like platelets, albumins, as an acute phase reactant, total bilirubin, BUN, blood creatinine, myoglobin, or even myoglobin, and more importantly, of course, the troponin. I, no, and C-reactive protein, and of course your interleukins, no, between these different groups. And majority of the patients actually died from the respiratory failure. But a close second, of course, no, is from a pure myocardial damage, no, and heart failure, or perhaps in combination with respiratory failure. So a total of 63% of patients in the death group and 41% in the discharge group actually also have underlying diseases. And patients with the cardiovascular disease have a significantly increased risk of death, no, among these patients when they are infected with COVID. So based on the analysis of this clinical data, the study confirmed that some patients died of fulminant myocarditis. So in this study, out of the few slides or the few studies that I've encountered, describing fulminant myocarditis or cardiomyopathy, this first reported that the infection of SARS-CoV may actually cause fulminant myocarditis. So given that fulminant myocarditis is characterized to be in rapidly progressing, no, and those patients who develop this would expectedly to be in a state of severe illness. These results, no, should alert, no, our physicians, no, to pay attention not only to the symptoms of the respiratory dysfunction but also to the symptoms of cardiac injury. So zooming in to some of the most studied causes, no, of the mechanisms of the cardiac injury, no, however, not well established, no, are likely the following. So there's an increased cardiac stress due to respiratory failure and hypoxemia. Now, it can be a direct myocardial injury, no, infection by the SARS-CoV-2, or an indirect injury from the systemic inflammatory response, or a combination of all these three factors. So case reports of myocarditis in COVID-19 provide evidence for cardiac inflammation, but they do not necessarily illuminate the mechanism. Thus far, I still have to see a study or an article demonstrating the presence of SARS-CoV-2 within the myocardial tissue, no, with definitive conclusion. So taking all this information together, it remains unclear how much of the cardiac injury is attributable to direct viral infection versus indirect systemic toxicity or inflammation. So furthermore, it is unclear which cell populations within the myocardium itself, no, are most vulnerable to infection and the systemic inflammation. So the ACE2 expression, again, no, levels may give us a hint, no, but again, the implications of such differences are detectable, are basically still debatable and maybe conjectural. No, so we're not sure of that yet. Okay, so given the difficulty of performing echocardiography, so this is the reality under strict isolation while wearing your personal protective equipment, and the associated risk to all the staff taking care of our patients, the exact prevalence of the COVID infection and the nature of the cardiac dysfunction in COVID-19, I would expect that it may never be really fully apparent, until we see studies, studying directly on this. So other facets of the cardiac involvement would include your blood pressure abnormalities and arrhythmias, as I've said, whether it's hypertensive or hypotensive. In fact, in a Wuhan cohort, a high proportion of your critically ill patients, and non-survivors have elevated blood pressure, at least initially, which is counterintuitive if you look at it, because in a critically ill, it's basically a vasophagic population. So, yeah, I guess initially they were hypertensive, but eventually becoming hypotensive or in shock, as the course progresses and people or patients dying of severe complications out of COVID. So whether this hypertension is simply a reaction to the illness or a predisposing factor to the illness, or a phenomenon related to the potential derangements in ACE2 expression, cannot be ascertained, from the different retrospective studies I've mentioned. And I hope our studies from UPPGH, will come up with this particular study or clinical design. So it is also important to note that in the different cohorts, including the critically ill patients in the Washington state, as I've mentioned a while ago, the patients were hypotensive. So most of these patients were hypotensive, admitting with an initial presentation of fulminant myocarditis. So patients are in shock. And these patients can also develop hypotension, and obviously may require vasopressor support most of the time. So this is basically the cohort of patients that I'm taking care of, and taking care of. Okay, so in addition to blood pressure abnormalities, patients can also develop arrhythmias ranging from tachycardia and bradycardia. As I've said, there are some epidemiological data on the evidence or incidence of palpitations, no? And they are in fact present in about 7 to 10%, no, of patients coming in as COVID infection, no? And a significantly higher proportion of critically ill patients who develop arrhythmia. So another entity which we should be always on the lookout for. Okay. Uh, okay. So although we haven't yet established, no, or characterized these different mechanisms, I think it's pretty obvious at this time, no, after mentioning all these different abnormalities, that arrhythmias can actually also, no, among this population, can also arise, no, secondary to these different mechanisms, no, particularly hypoxemia, metabolic derangements, no, uh, systemic inflammation, or myocarditis, no, and basically uh, also consistent, no, with the different mechanisms that I've mentioned a while ago in my previous slides. So it is currently believed that the myocardial damage, no, may actually represent, no, a main driver of enhanced arrhythmic risk, no, in these patients. No. Cardiac myocyte injury reflected by increased troponin levels, no, was demonstrated in many individuals, no, particularly in those with severe disease. No. However, the evidence provided that in ICU patients, no, in this study, no, despite the high frequency of arrhythmias, around 50% of the cases, only a half showed acute cardiac injury with median troponin I levels falling in the normal range, no? Which basically suggests that factors other than myocardial damage are also involved in enhancing the arrhythmic risk, no, in COVID-19 patients. So it's not just basically direct invasion or damage to the myocardium, but perhaps let's look into how we manage our patients. So in this regard, the potential role of pharmacologic treatments, no, in increasing the susceptibility to QT-related life-threatening ventricular arrhythmias, particularly your torsade, no, which we see a lot, no, among our cardiac patients, no, is being increasingly recognized. No. In fact, some of the off-label drugs used to counteract the virus, no, the virus invasion and replication, may actually promote QTC prolongation. No. So some of these medications, no, even antibiotics, can actually do that or enhance QT prolongation, which can lead to this fatal arrhythmia. So this is the case of the medications that we use, no, particularly your chloroquine, your hydroxychloroquine, your anti-malarial agents that blocks infection by increasing your endosomal pH, no, which is required for virus or cell replication. Your lopirito or lopinavir and ritonavir, no, so other antiviral agents which can also enhance QT prolongation. Your protease inhibitors, interfering with the virus RNA replication. So notably, in both cases, no, the impact of ventricular repolarization is direct, no, via the inhibition of a certain enzyme, your HERG potassium channel and your calcium channel, and also by indirectly increasing circulating levels of other concomitant QT prolongating drugs. Okay, so if you have those chloroquine or hydroxychloroquine, uh, just be careful in using that. So our the evolution of our management among our patients in the Philippine Heart Center has actually evolved from something like trying all these medications, no, in some of our patients, even with those presentation of heart failure for as long as their QT is not prolonged, into something like not giving all these medications at all. So we're really just being careful among with these medications, and the evolution of our management basically is just strengthening the supportive care and just giving some medications based on their clear indications. Okay, so finally, an acute coronary syndrome. So acute coronary syndrome and acute myocardial infarction, no, can actually occur in patients with COVID-19. But again, the incidence of such events is unclear. So just a review. So on the key manifestations and hypothetical mechanisms. So you have the SARS-CoV anchoring on your transmembrane ACE to enter into the cell, including your type 2 pneumocytes again, the macrophages, epithelial cells, pericytes, endothelial cells, no, infecting all these different cells, no, leading to a microvascular and macrovascular dysfunction. So furthermore, in conjunction with the immune overactivity or the cytokine storm, it can potentially destabilize, no, the different the different plaques, no, among our coronary artery disease patients, and explain the development of the acute coronary syndrome. So infection of the respiratory tract, basically, particularly the type 2, no, pneumocytes by SARS-CoV-2 is manifested by the progression of this systemic inflammation and immune cell overactivation, leading to your cytokine storm, which results in an elevated level of these different inflammatory mediators, as I've said, the 6, 7, 22, and your CXL10 or your interferon. Okay, and subsequently, it is possible also that activated T cells, no, and macrophages may infiltrate the myocardium itself, creating fulminant myocarditis or myocardial damage, no, resulting in the development of a severe cardiac damage. And this process could further be intensified by the cytokine storm. And similarly, this viral invasion could cause cardiac myocyte damage directly, leading to fatal arrhythmias. So that's basically, again, as a review on how these things are happening on our cardiac patients or even our non-cardiac patients, however, with comorbidities or cardiovascular comorbidities. So in principle, the risk of acute coronary syndrome in afflicted patients may be increased due to the heightened thrombotic activity or the proclivity to, as I've mentioned, to hypercoagulable state, no, as evidenced by significantly elevated D-dimer levels. No? So in this study by Dowell et al., no, D-dimer was likewise seen and significantly increased among patients with COVID, particularly admitted in the ICU. So underlying this risk, no, are probably known predisposing factors related to inflammation, no, like your atheromatous plaque, platelet activation, tissue factor expression, no, and further elaboration of your inflammatory mediators, no, like the interleukins and the interferons that I've mentioned. So uh, yeah, so this retrospective review, no, from 2 hospitals in China also mentioned uh, the elevation of the D-dimer, no, of about more than 1 microgram per ml. No? And as it turned out, patients who had elevated levels of D-dimer would have higher mortality versus patients of lower D-dimer values. And again, the established risk factors consistently were the following. No? So acute illness, patients who are bedridden or frail, no? Some genetic predisposition, although not really established, and inflammatory manifestations. And the predisposition to inflammatory response, no, coupled with hemostatic abnormalities, can actually give you these different cardiovascular clinical outcomes. And the elevated D-dimer is actually a common finding, no, in patients with COVID-19. And based on my readings and observations, no, it may not necessarily, no, warrant routine investigation for acute VTE, no, in the absence of clinical manifestations or other supporting information. So if you have clinical suspicion on the background of D-dimer, then since the workup is costly, then by all means you can work the patient up for possible pulmonary embolism or venous thromboembolic phenomenon. Okay. However, if there's no clinical manifestations, you can probably just hold it and observe, no, as the disease progresses. So interestingly, clinical studies on prior epidemics corroborate, no, these observations, no, by showing a strong association between viral respiratory infections and acute myocardial infarction. So this study, no, found significant association as to the causality of MI with a precedent viral prodrome or viral infection. So yeah, this would actually show that. So although robust data on the scope of acute myocardial infection, myocardial infarction in COVID-19 are not available yet, hopefully soon. Acute myocardial infarction did not contribute to in-hospital mortality in the SARS epidemic previously. No? So I still have to see data on how this is, no, with the present COVID infection. So just to brief you, no, and give you insight as to what's exactly happening in the Philippine Heart Center. So we have a total of 244 patients from suspects to confirmed. About 237 of them were adults, 80 are confirmed with one pediatric patient. 42 were males, no, so still more than the number of females. With the age ranging from 23 to 92, with the mean age of 50, and about 14 of them expired, including the our two colleagues, one senior cardio consultant and our cardio fellow, no, unfortunately. And again, consistently with the different studies I've already presented, the comorbidities that are really predominant were hypertension, no question. Type 2 diabetes, those who already have pre-existing coronary artery disease, no, or those patients, including those patients who got admitted for acute coronary syndrome, and those patients who got admitted for post-revascularization. CVD infarct, arrhythmia is also common, and subsequently followed with bronchial asthma, valvular heart disease. Those patients would have CKD already, COPD, a few of cardiomyopathies, and acute decompensation from congenital heart disease. And some patients would actually already have TB. Okay, as I've said, no, I'll just touch on a little on the therapeutics, no, and some mention of the diagnostic considerations, no, looking into the background of how unsafe some of these medications are on our cardiac patients due to QT prolongation. So, as you can see from here, the different rationale for COVID-19 treatment, by these different therapies, divided into your antimicrobials, your immune modulators, and cell-based therapies. So, I am really not so confident in mentioning these other uh, modes of therapy because I still have to experience it. Well, I was able to experience infusion of intravenous immunoglobulin in the other center I'm affiliated. But again, this is just to show you that despite all these different modalities, or strategies of treatment based on different medications, nothing has really been proven yet to be really 100% effective or as a definitive treatment of COVID-19 infection. And this is a very good slide showing that for our subsets of patients or our cardiovascular patients or even non-cardiovascular patients who already present with cardiovascular manifestations, we should be really careful in resuming or perhaps initiating these different medications based on these different side effects. So a lot of these patients really will have their QT interval prolonged. No, there's concomitant thrombocytopenia and anemia. For the antivirals, you have again consistently thrombocytopenia, hemolytic anemia, derangement of the metabolic profile. So some biologics like tocilizumab, which I am fortunate to have experience in some of our patients, however under very strict rules of indications and contraindications, and several warnings on cardiovascular toxicities of these different antivirals, antimalarials, and biologics. So in general, this has to be used in caution. This has to be used based on indications and strict indications and contraindications, because more often than that, especially for cardiac patients, they're more detrimental than beneficial, which brings me actually to say that what we should be really strengthening is the supportive of care. So this is a diagnostic test in patients with COVID-19, which was seen in one of the articles I've read. Uh, and studies I've seen from Medscape. These are the following, at least at the minimum, okay, especially for cardiac patients, that I would also recommend being tested among our patients who are cardiovascular patients or develop cardiovascular complications in their admission. So it's NT-proBNP, especially for our patients who come in with acute decompensation. So there are conflicting data on NT-proBNP in MERS-CoV cohort. So it was increased, but it may be normal in COVID-19 affected patients. So higher NT-proBNP levels in the Chinese cohort were associated with a greater need for ICU care. Definitely troponin T, I don't think I'll further elaborate on that. It's a no-brainer. D-dimer reports from the initial outbreak in Wuhan show a key relationship with the requirement for ICU care and mortality. Again, both the D-dimer and troponin being a good marker and prognostic marker at that with regards to the clinical deterioration or progression of patients. Procalcitonin is also a good measure because at least you'll have parang a backgrounder of the infection status of our patients, whether patients is already in sepsis, no, or suggestion of infection. Full blood count always is necessary, the CBC. And if your institution has it, no, you can actually request for IL-6 because of its high specificity for COVID-19 with regards to inflammatory process. Ferritin is actually an indirect measure of your IL-6. We have this in the Philippine Heart Center. I'm not sure if other centers would have it. Of course, cardiac CT, which in the Philippine Heart Center has evolved from shooting a cardiac CT scan, no, or getting cardiac CT scan in all our patients. And then, fortunately, the institution has actually devised, no, a risk scoring, no, or a policy with regards to who gets to get the CT scan and, or not, no. And of course, ECG very important, especially if you have to look into the dynamic STT wave changes, no, which is somehow more common among our patients who develop arrhythmia or ST segment elevation MI, and of course echocardiography, particularly if you really want to diagnose, no, somehow as part of the diagnosis, but not necessarily the gold standard would be on fulminant myocarditis or cardiomyopathy. All right, so supportive treatment. So this is basically what I would like really to share, no, to our comrades, no, or to our colleagues, no, in the different parts of the Philippines, no. So I would suggest that you be really careful, no, on your fluid administration. So there has to be a very thoughtful fluid administration. So the mantra is to be gentle, no? So to not be really aggressive on these patients, no, uh, unless you have a very good reason to actually resuscitate and give a lot of fluid boluses. But at least uh, uh, be gentle on the introduction of fluids, no. So a lot of these patients would be hypoperfused or hypovolemic, no, because of prolonged nausea or vomiting or even diarrhea for some of our COVID patients or those with suboptimal feeding who are relatively in a state of hypovolemia. The one that is being recommended, at least from the guidance from the surviving sepsis guidelines, no, is the 30 cc per kilogram fluid. No, at least at the aspect of managing cardiovascular patients, this should be avoided because it can further, no, aggravate the already overloaded patients, particularly those who are already congested or those experiencing pulmonary congestion. If you have a hypoperfused patients or hypovolemic patients or hypotensive patients, so better to do, it's acceptable to initiate low dose vasopressor to actually support the map. So that's the priority. If you don't have a good map, if you don't have a good blood pressure, don't expect to have a good heart. And if you don't have a good heart, no, as what our Doctora Mejia, no, a former teacher of mine, if you don't have a good heart, you definitely won't have a good kidney. So one very good guidance, no, in terms of fluid administration is following these mnemonics. No, there are ROSE, which is basically stands for resuscitation. So initial resuscitation, careful resuscitation, or gentle fluid resuscitation, optimization, no, stabilization, wherein you basically de-escalate, no, or just stabilize the patient, not necessarily giving so many fluids, and de-escalate, or basically retrieving all these fluids that were inside the body during the time of the inflammation. However, taking into consideration the hemodynamic stability of the patient. As a general rule, you may discontinue, no, home antihypertensive agents, no, particularly your ACE and ARBs, no, because they're potentially nephrotoxic. So basically, that's the setting wherein you will prioritize discontinuing these RAS blockers, no, because they're nephrotoxic. No, they should be avoided in our critically ill patients who have impending organ failure or threat, no, in some of the core organs or important organs, particularly your kidney and your liver. Most of these patients, lalo na po yung mga critically ill, are on sedation, no, and positive pressure ventilation. So this group of patients are also under the threat of hypertension. That's why you do the fluid conservative strategy only for ongoing losses, no, or resuscitation for ongoing losses. No, if patient is stable, then just make sure that they're eating enough or drinking enough. If they're unstable, you can somehow prioritize, no, along the way the initiation of your low dose vasopressor to actually support the map. How about troponin elevation? Again, troponin elevation, just like the D dimer, is very common. There's especially the high sensitive troponin. So among the non-survivors, the troponin tends to increase steadily from 4 days of illness to day 22 and beyond. No, and the potential causes of troponin elevation in COVID-19 patients. No, to answer the second question in the pretest question, would be the following. So you have the myocardial injury wherein troponin elevation without symptoms, EKG, echo findings, or myocardial ischemia. You have the type 1 or the plaque rupture. This is probably the least common causes, no? But you have the type 2 MI or the stress MI, which is basically brought about by the severe inflammation and the stress that the heart is experiencing out of the metabolic imbalance, no? Especially from patients developing acute respiratory distress syndrome. And of course, stress cardiomyopathy, which can be in any form like your Takotsubo cardiomyopathy or the viral cardiomyopathy. So the recommendation is investigation should focus on integration of your ECG, your echocardiographic findings, as well as the clinical context of the patients. In cardiomyopathy, however, it can occur. Fulminant cardiomyopathy can actually occur, and this may be a late feature. No, and in fact, personally, my observation, this has been the case of one of our colleagues, no, so who, two of our colleagues who actually deteriorated, uh, I think around day 15 or 16. So both of them died uh, 2 weeks after. No? So presenting, I think, no, fulminant cardiomyopathy. So this can occur even after patients are even recovering from the respiratory failure. Cardiogenic shock appears to be an important cause of death, contributing to 7 to 33% of deaths. However, it's unclear whether this represents a viral cardiomyopathy or a cardiac dysfunction due to cytokine storm. So the recommendation is for the evaluation, make sure you have your EKG wherein you will see dynamic changes, echocardiography definitely, and troponin levels to evaluate for acute coronary occlusion that brings about, the sudden deterioration of the hemodynamics or hypotension. So shock, these are rarely present, no, upon admission. In fact, even septic shock, no, it's very rare. No? Some of our patients would present with normal procalcitonin, only with simple pneumonia, but will deteriorate eventually and will be admitted to the ICU. No? So this can be a late finding among our critically ill patients. No? And the potential causes are the following. So myocarditis from cardiogenic shock, secondary bacterial infection with septic shock, of course, cytokine storm, or hemophagocytic lymphohistiocytosis, which is a form of cytokine storm, pulmonary embolism, pulmonary hypertension due to excessive mean airway pressure via PEEP or CPAP, no, and anaphylactic reaction. In some cases, anaphylactic reaction to some medications. So the evaluation is basically a complete septic workup. So you have to rule out sepsis, no, and think of a combination of sepsis and a cardiogenic shock, no, in some of the cases. So definitely a mainstay would be a bedside echocardiogram and physical examination, and definitely a review of serial lab examinations for cytokine storm. As I've mentioned, it's a little expensive not to manage to manage COVID-19 patients, mainly because of these different inflammatory markers, which you will need to monitor regularly, like every 3 days, especially if they're really toxic or hemodynamically unstable. Of course, the treatment, no, would still include supportive care, fluid administration, of course, nutrition, sedation of patients, no, and the other necessary monitoring that is included when you manage an ICU patient or even non-ICU patient. Of course, vasopressor support as guided by echocardiography and physical examination. Definitely empiric antibiotic therapy if there's concern for septic shock. Corticosteroid therapy may be considered, no. However, if with indication, no, especially if refractory to vasopressor therapy, or if sepsis or cytokine storm are considered likely. And in some cases, no, inhaled pulmonary vasodilator could be considered for intubated patients with acute cor pulmonale. Okay, so that's why we also monitor rigorously the function of not just the LV but also the RV because of some incidents of pulmonary embolism that brings about acute cor pulmonale. All right, so I'm on the last stretch of my lecture, and before I end, no, let me just highlight this question of why is it that there's a greater risk of acute cardiovascular events, and why are patients at higher risk of severe complications during the pandemic? I think this is very obvious, no, even in the local setting. No, I'm sure most of you will we'll observe that the reasons mentioned in these ESC guidelines are pretty much consistent, with what we're experiencing here in the local setting. So, of course, there would be delays, in accessing to the hospitals and the intensive care. And for those needing revascularization, it's really hard to get a hospital that will open their cath labs for you, especially if they suspect that you have COVID-19 infection. We're locked up. We're locked up 3 months for 3 months now, and isolation is actually taking its toll in a lot of our patients. No, in a lot of the people outside. No, some creating depression. No? So of course, you'd expect that the physical activity will also be reduced. No, and people eating smorgasbord diet. No, so you'd expect some increases in body weight among the people, and of course increased smoking due to inaccessibility of healthcare practitioners. You'd expect that there will be poor or worse control of hypertension and diabetes because of reduced adherence to treatment, and some of patients being or those who developed acute myocardial infection would actually go to the hospital in their late presentation or when they're in shock. And in some cases, there are some negative influences coming from fake information from media and the websites. So basically, all these things and more are also consistent with the local setting based on my observation. And with that, I would like to end this lecture with some key considerations and personal recommendations as to how we can take care of our COVID patients in general, or COVID patients who have cardiovascular, pre-existing cardiovascular disease, or those who develop cardiovascular complications. So we all know that cardiovascular disease patients are basically compared to other sets of patients are always at increased risk of severe complications. And the recommendation, of course, is to intensify preventive measures and follow what is being said in our local guidelines, which is basically in accordance with the World Health Organization and CDC guidelines. So I think what is being suggested nowadays is the wider use of telemedicine tools in the day-to-day monitoring of patients during the outbreak to limit their exposure. I used to go on rounds every day nung kainitan pa po ng COVID, but realized later on with the telemedicine to limit somehow to limit my exposure to our COVID patients. I do alternate rounds every day and rely on some form of telemedicine like the Viber or Zoom. We would somehow do Zoom rounds in some cases that are very problematic together with the other members of the strike team. So the heterogeneity also of the responses between individual patients indicates that it is also unlikely that it can be considered as a single disease phenotype. So based on host characteristics, so we can expect different presentation of the patient. So the most common cardiac complications, as I've seen, were arrhythmia, acute coronary syndrome, those who develop, although a few, fulminant myocarditis and heart failure. And the cardiac complications generally appears around this day, day 14, day 15, and beyond. And the evaluation of cardiac damage rely mostly on troponin I, some with CKMB, of course, definitely D-dimer. So some subsets of patients who come in acute decompensation definitely has to be evaluated for NT-proBNP, and of course the reliability of the echocardiogram. The medications, however, are still unconfirmed for the COVID-19 treatment. And let's all be careful because some of these medications can contribute to the cardiac toxicity. I would advise consistent measurement of QT prolongation, at least at a baseline, or those with comorbidities like hypertension and cardiovascular disease. Hypertension is still one of the most common risk-associated comorbidities, but it is associated and co-founded by age. So it is not clear whether this hypertension is age-independent risk factor for COVID. But as a precaution, it is essential that hypertension remains well controlled. So again, there's really no evidence that ACE inhibitor or ARB are associated with worse prognosis. And patients should not discontinue the use of these medications unless there's a contraindication to their use, as I've mentioned. So the most common, again, to answer the question, the most common mechanism for the MI that we're seeing, I think based on the studies that I've read, no, is the type 2 MI, no, or the stress MI, or an MI that is brought about by a persistent inflammatory process, no, creating imbalance between oxygen demand and supply. And of course, as to the role of the ACE2, no, so ACE2 I think can be considered as the link, no, or the Cinderella of the cardiovascular medicine. So it's a molecule which has been underappreciated, no, in the cardiovascular pathology, but is very much appreciated now, no, and is taking center stage, no, in understanding and potentially combating COVID-19. So I guess I'll end with that, and at this point, would entertain questions, no, from the audience. No, I also saw some questions posted earlier uh, before I started my lecture. Thank you very much for staying.
Thank you very much, Dr. Chito. Raymond, you wanted to recap on the two correct answers?
Just for those two correct answers po, no, I will need poll questions. But before that po, we have for our attendees benefit po our evaluation of the presentation that was given excellently by Dr. Chito Permejo. So napaka ano po informative ng kanyang presentation po.
100% pareho.
Yes, on the standard of care po
Thank
for
you.
care management. It was very well received, Dr. Chito, and a lot of the comments here, particularly for your presentations, evaluation, goes to show on the extent of your preparations, Puser, and then the content po that you shared was indeed very much well received by our attendees. Thank you so much again,
Thank
Dr.
you.
Chito. Since we are pressed for time, I think we should go ahead with the pre-test questions, the answers to them. I could have them shown on the screen right now.
All
Okay.
right.
So for question number 1, it reads, aside from lymphocytopenia, which cardiac biomarker has good prognostic value in COVID-19 infected patients? Is that troponin I, Dr. Chito, or did I
Yes.
miss that?
So the answer is actually D-dimer and troponin I. No, they're
Okay
very
po.
good prognostic markers. Now, it's not even the NT-proBNP because we select those patients, we request for NT-proBNP. So those are patients with perhaps acute decompensation or eventually who developed acute decompensation along the way. But as a baseline, no, we request right away for D-dimer because we know that these patients are really predisposed to hypercoagulation.
Okay, and that was the answer given by 50% of the respondents. So talaga nakikinig po sila, sir. Number 2 is, it reads, this is said to be the most common mechanism of ACS among
Mm.
COVID-19 infected patients. And the answer
Yeah.
is?
Type 2 MI. So this is a little unfair, no? It's a little tricky because it can be type 1 or type 2, no? So again, based on my readings, no, and based on what I was trying to emphasize, no, I think chances are the main reason for the MI will be really coming from the stresses, no, coming from the COVID infection itself. No? So as I've said, it's a hyper-inflammatory process, and the chances of imbalance between oxygen demand and supply is very likely, and it can hit even patients who don't have pre-existing cardiovascular disease. So it's a little tricky. We still have to see studies that would link really the type 2 as being the most common mechanism. But at this point, I would based on my opinion, based on humbly from what I read, no, I think this is the more logical type, other reason for the mechanism. It may not be the acute pulmonary embolism, no, so as suggested by the D-dimer. So because it has to be again documented with a lot of things, no. So you see a lot of RV dysfunction, or you see you have to actually document it, getting a CTPA, no, or pulmonary angiogram, no, in most of the time to really document it. So it's really hard to say it's acute pulmonary embolism right away. There's while cardiomyopathy is seen, it's still a few as compared to the different types of MI that we see, in our patients. Not just personally, not just in the Philippine Heart Center, but also in the other institutions I'm affiliated. So there you go.
Thank you, Dr. Chito. I think we have only time for like 1 to 2 questions. If you could maybe give like brief answers to them, sir.
Yeah, sure.
Covered patients who were given hydroxychloroquine as treatment, do they still need to watch out for arrhythmia even after discharge? Kasi mayroon daw po bang possibility that a heart problem will develop as a side effect po of the disease?
Yes, that's very good. Actually, as I've said, no, even with in my slides, no, even with very low viral load, no, so you see a lot of these complications still going on, and even after discharge, no, some of these patients are getting readmitted, no, for the same reason, no, so a shortness of breath, chest pain or chest discomfort. So, to be safe, no, I think a safe answer would be to still monitor, no. That's why when you're discharged, actually you're still quarantined, if I'm not mistaken, if there's an infectious disease in the audience. No? So when you're discharged, you're basically not yet off the hook. No? So you still have follow up, at least perhaps with via telemedicine. And I would suggest getting an ECG as a follow up monitoring. No. Especially if you already develop QT prolongation during the course of your treatment with hydroxychloroquine.
Okay, we have just our last question.
Yes,
What
ma'am.
advice can you give to physicians who have underlying cardiovascular disease or who have undergone cardiac revascularization procedures, CABG or angioplasty, whose clinical practice involves frequently performing aerosol generating procedures?
Yes, ma'am. That's uh, that's actually a very important question, no? Especially for our colleagues. No, in fact, uh, in the Philippine Heart Center, no, I'm really not sure about this, but allegedly, some of the patients, no, or some of our colleagues actually contacted the disease or the COVID-19 from a procedure done at the cath lab. So as a precaution, no, to our colleagues, I think it would be better to be really safe, no, to observe precautionary measures, no, nowadays. I think we've learned a lot, no, and we're better now, no. It was just that previously we weren't really adept, no, in managing because we really don't know what COVID-19 is and how it can affect us. No? That's why the spread, no, of the virus, even for our healthcare workers. No? So I think we're better now, no? Even though it's an aerosolizing procedure, no, with the different measures or precautions that is being observed, no, in this particular procedure. While I would advise to limit it to just an emergency procedure and perhaps take a step back with regards to some elective procedures, no? So as just to limit the exposure. I won't stop them from doing it. However, of course, observe some precautions. Of course, with the new normal, no, some standards have already been set, no, with regards to protection. So PPEs, no, of course, goggles, no, the works, no, hazmats and everything. So perhaps, yeah, generally, siguro mga emergencies muna, no, just to limit the exposure. In fact, ako nga po, dati alos everyday, no, excluding weekends. Ngayon medyo tame na lang po muna ng konti. Kasi kung tayo naman ang magkakasakit, sayang naman po at marami pa tayong matutulungan. So,
Yeah, thank you very much,
yeah,
Dr. Chito. Thank you so much. That was a wonderful
thank you rin po.
presentation. I think our audience really appreciated it. We are sending you, with Dr. Chito's permission, a copy of the presentation. Is that
Of course,
okay?
ma'am.
Yeah,
Yes,
okay.
ma'am.
So thank you so much for your time,
Thank you.
for all the effort you put into this. And to
Yes, ma'am.
close our program, we'd like to call back Dean Charlotte Chiong just to say a few words.
Well, I really enjoyed the lecture. Thank you very much for inviting me. Tutukan po natin ang Grand Manyanita sa UP Diliman. Ongoing po.
Thank you, ma'am. Yes, ma'am.
Okay, thank you very much, Dean Charlotte, and for being with us. Next week, we're going to hear more about what's happening in Cebu and how they're managing their patients there. So we're going to have Mitzi Chua, who is the head of infection control at Vicente Soto Memorial Medical Center. So watch out for that one. Raymond.
Thank you, Dr. Chito, for that excellent presentation. Thank you too to Dean Charlotte
Thank
for
you.
staying on and giving our closing remarks po. We will not forget for that Grand Manyanita, ma'am, and also to Dr. Susie Mercado. And on behalf of the team, we would like to thank for all our 130 plus attendees for staying on for the last 2 hours for this webinar. Makita-kita po tayo ulit next week for our resource speaker who will talk about their experience po in Cebu, specifically in Vicente Soto. Maraming salamat po at magandang araw ng kalayaan po sa ating lahat. Please keep safe, keep healthy, and see you online. Thank you so much.
Thank you.